All right. So we'll kick things off with a bit of context regarding the ongoing pandemic. Then from there, we'll move on to three of my research group's recent studies that employ machine learning methods to better understand COVID-19. Because we have limited time today and I want to leave enough time for questions, I'll keep my overview of each study high level, covering the research questions first, then the methods used to address them, followed by results, policy recommendations, and related work. For those who want to learn more, all three studies have been published already and are open access. I've included citations throughout my slide deck to make it as easy as possible to find them. In addition to reserving enough time at the end of this session for a Q&A, hopefully I will also be very open to responding to questions on Twitter. Most of these slides have my Twitter handle in the top left corner. Okay.
Should people ask questions also during the presentation or wait till the end?
I think that if folks want, they can pop questions into the chat and let's try to take them at the end so we can have kind of more of a dialogue and a free-flowing conversation. I'll try to keep things as short as possible and have enough time at the end so we can really have a discussion. Okay. All right, so to kind of provide some research context, as many of us are aware, there have been nearly 67 million cases of COVID-19 reported worldwide since late 2019. This particular disease is caused by the novel coronavirus SARS-CoV-2, which is shown on the right here. These cases comprise only a fraction of total infections, though, due to something that we frequently call underdocumentation. Underdocumentation has many causes, including the fact that many SARS-CoV-2 infections are mild or asymptomatic in nature, as well as insufficient volume of lab testing in the early days of the pandemic, a problem that still persists in under-resourced communities, both in the US and around the world today. Another reason for underdocumentation in the early days of the pandemic was simply because cases were often misclassified. The earliest cases of COVID-19 presented as pneumonia, which can have many causes beyond SARS-CoV-2 and may thus have been diagnosed as something else at the time. As is an issue with any novel pathogen, there's a learning curve associated with discovering even the most basic attributes of its characteristics in humans and its behavior in our populations. For instance, though transmission of SARS-CoV-2 started in Hubei, China in late November 2019, it wasn't until late January 2020 that sustained human-to-human transmission was suspected, which is when my group began researching the novel coronavirus and its epidemiological characteristics. Our earliest work involved assessing the transmissibility potential, often described as the base reproduction number, or R0. It's often denoted as R sub 0, associated with SARS-CoV-2 in Hubei, China. The base reproduction number is often defined as the average number of secondary infections caused by a single index case in a fully susceptible population. As a result, it's population specific and varies across contexts, which is a very important thing to remember for the remainder of this talk. One can imagine, for example, populations where individuals have many daily contacts may exhibit higher values of R0 than populations where individuals have fewer daily contacts. In a population where R0 for a given pathogen is estimated to be greater than 1, we expect that the pathogen has epidemic or pandemic potential. However, because R0 can't be directly observed in nature, we need to model it. There are a lot of different models that let us estimate R0, but early in the pandemic, we had so little data available that we decided to take a simple phenomenological approach to its estimation. Phenomenological models, for those on the line who may not be aware, are strictly descriptive in nature. In other words, they can't tell us anything about the underlying mechanism of disease transmission in the population, but their advantage is that they require very little data to calibrate. My group's estimate for R0 was the first on record, but was quickly followed by several others, which is shown on the right through a study we conducted in February. Though there was variability across the estimates, the mean was pretty consistent across studies, indicating that the R0 associated with SARS-CoV-2 in Hubei, China, in the earliest days of the pandemic was likely in the ballpark of 2 to 3, which is obviously much higher than 1. As the epidemic in Hubei quickly turned into a global pandemic, however, my group started to wonder just how different R0 was across locations and how the various non-pharmaceutical interventions that were implemented around the world would impact transmission in the months ahead, especially as new waves of transmission began in response to calendar events like people going back to school or, as is now coming up, the holiday season. Given the complexity of the new questions we were interested in, we decided to take a more complex machine learning approach in the form of agent-based modeling to address them. However, agent-based models, or ABMs, haven't been the only machine learning application my group has explored within the context of the pandemic so far. Prompted by how quickly the basic reduction number studies shown on the right of the slide were produced back in early 2020, we also became increasingly curious about the speed at which the scientific community was working to fill existing knowledge gaps to better understand the novel coronavirus. We were especially interested in understanding whether certain fields within the broad umbrella of something that I like to call outbreak research were experiencing more rapid information generation than others. So to answer this question, we turned to natural language processing, or NLP, techniques like principal component analysis and latent Dirichlet allocation to sift through the thousands, and I truly mean thousands, of new studies that have been produced in response to the pandemic so far. During this bibliometric analysis, though, my group became increasingly curious about how gaps in knowledge might also lend themselves to the proliferation of misinformation. Because of the political context of the pandemic in the US, Americans have been particularly vulnerable to misinformation during this pandemic. Thus, with an eye towards developing better monitoring and mitigation strategies for public health misinformation, my group tapped into novel digital data streams like news media data and search query data to investigate misinformation events here in the US. These three broad research areas, ABMs for epidemic dynamics, NLP for bibliometrics, and news media and search query data for event-specific surveillance of misinformation events, comprise a few of my group's core scientific interests. And today I'll be covering three recently published studies that offer a taste of the work that we're doing within each of them. So without further ado, let's get started with ABMs for epidemic dynamics. The paper I'll be presenting in this research area is cited at the bottom of the slide, and it's also the first study in an ongoing collaboration between my group and Millens, and was led by our very own Brian Wilder, which is why I thought it would be perfect to cover with the group today. In this paper, there were three big picture research questions that we aim to answer through our agent-based modeling approach across three different populations of interest. Hubei, China, where the pandemic began, Lombardy, Italy, one of the hardest hit locations worldwide in the early days of the pandemic, and New York City, one of the hardest hit locations here in the US. Recalling the context dependence of the transmissibility potential associated with a given pathogen, the first question we wanted to answer was, how does R naught vary across locations? Second, recalling issues with documentation of infections that I mentioned at the forefront of this presentation, how does documentation rate vary across locations? And finally, recalling the number of non-pharmaceutical intervention policies that have been deployed around the world since the beginning of the pandemic and how said policies may impact transmission in the months ahead, what is the impact of varying policy recommendations during a new wave of infections across these locations? Our choice of an agent-based model to answer these big picture questions is perhaps best explained by digging into what an ABM actually is within the context of modeling epidemic dynamics. ABMs in our use case can probably be best described as mechanistic infectious disease models that simulate individual people or agents who are assigned predefined characteristics based off of existing data on the population or populations of interest, including things like region-specific contact matrices, household structure, age, sex, comorbidities, and a whole host of other things. The description cards shown on this slide describe some of the attributes that are defined for a given agent or individual to address the aforementioned variability that we expect across populations for three questions of interest. By defining each agent's characteristics based off of population-specific distributional data, we're able to simulate epidemics within a version of each population, including how interventions may curb disease transmission in said populations. Clearly, ABMs require a lot more data and computing power to parameterize than simpler models, which is part of why we didn't use this kind of approach early on in the pandemic. However, unlike simpler models, they can lend important insights into more complex questions like the ones that we were interested in answering in this particular study. To simulate epidemics in each of our populations of interest, we fed the agents for any given population through a susceptible, exposed, infectious, and removed, or SEIR style model, as is shown here. We used contact matrix and household structure data specific to each population of interest to inform transitions from the susceptible state to the exposed state, and we further partitioned our infectious state into four categories: pre-symptomatic, mild, severe, and critical, each of which were also assigned a probability of transitioning to one of the two removed state categories, recovered or deceased. Folks on the line are probably familiar with SEIR models of the traditional compartmental variety, which are typically defined by ordinary differential equations and treat each member of a given compartment as identical to one another when they are considered in their simplest form. In these simpler models, all members of the susceptible compartment have the same probability of transitioning into the exposed compartment. All exposed members have the same probability of transitioning to the infectious compartment, so on and so forth. These kinds of models are popular because they are much less computationally intensive and complex than ABMs. However, they aren't optimized for taking into consideration non-pharmaceutical intervention policies and their impact on transmission, an issue that is particularly important for our three populations of interest given shelter-in-place orders that took place at each location. Furthermore, they can't capture the individual level variability that make agents different from each other, an issue that is especially important when considering the fact that intervention uptake occurs at the individual level. In other words, just because a non-pharmaceutical intervention policy is enacted in a given population doesn't mean that every group within that population will actually comply with it. This was particularly critical to our research interests because we wanted to specifically investigate the impact of age group specific sheltering in place and physical distancing on transmission dynamics during potential new waves of spread in Hubei, Lombardy, and New York City. To parameterize our model shown on the previous slide, we used a combination of empirical estimates and free parameters, as is shown in this table. Notably, the probability of infecting an out-of-household contact is a free parameter that plays a really important role in estimating R0 across locations. Distributions for free parameters like this one were estimated using a Bayesian inference framework by fitting death trajectories for each population of interest against ground truth death trajectory data. Death trajectories were used as opposed to case counts over time because deaths have generally been a more reliable indicator of outbreak progress across locations throughout the pandemic. Though deaths obviously lag behind infections, they're less likely to be underdocumented than non-fatal cases of COVID-19. That said, we did use ground truth data on case counts to estimate the documentation rate across locations by dividing reported case counts by the number of infections as ascertained from our ABM for each location. Our ABM fits against the ground truth daily death data for each population, shown in small black dots in the three panels in this figure, were quite good across locations. The green line shows a median trajectory from our ABMs, and the light blue how individual samples from the thousands of simulated epidemics that we ran for each location. The red dotted line indicates when ABMs for each location initiated a reduction in contact across the population in response to non-pharmaceutical intervention policies, such as sheltering in place orders. These policies were implemented at different times across locations, as is clear from the x-axis for the three panels, because these three outbreaks occurred at different times. The factor by which contact was reduced following shelter-in-place orders varied by location. While information on this parameter was determined empirically from a survey study for Hubei, it was treated as a free parameter for Lombardy and New York. We did, however, compare our estimates for contact reduction in New York against mobility data from the company Unicast and found that our estimates were pretty similar. To further validate our fits against death trajectory ground truth data, we conducted sensitivity analysis under varying assumptions of underdocumentation for deaths, as well as out-of-sample validation, which is detailed at length in the supplementary materials for this paper. Once we felt assured of our fits against the ground truth death trajectory data, we were able to estimate R0 for each location, as well as the documentation rate. Substantial differences in R0 are visible across locations, as shown in the top left panel, with medians of 2.23 for Hubei, 2.95 in Lombardy, and 3.2 for New York City, thus demonstrating important population level variability. R0 values as estimated through a sensitivity analysis in which deaths were assumed to be underreported in Lombardy and New York City, which, unlike Hubei, were still developing outbreaks at the time of this analysis, is shown at the bottom left panel. And notably, the relative orders of magnitude across locations remain unchanged. Substantial differences in documentation rate are also visible, as shown in the top right panel, with consistently low documentation rates across locations, rates that are further reduced when conducting a sensitivity analysis in which deaths in Lombardy and New York City are once again assumed to be underreported, as is shown in the bottom right panel. Despite low documentation rates across locations, though, all three populations remained vulnerable to a new wave of infections as of this past summer, which is when this paper was in preparation for publication. More specifically, our models suggest that only 1.3% of Hubei, 13.8% of Lombardy, and 22% of New York City were infected by the end of our modeling periods for each location, the latter of which has been confirmed empirically via serological survey. Given the susceptibility of all three locations to further transmission of SARS-CoV-2, we investigated the possible impact of various shelter-in-place strategies to curb transmission in the event of a new wave, especially as we wait for vaccines to roll out, with a focus on age group-specific interventions. Here, each column shows a different level of physical distancing by the population of interest, where contacts between all age groups are reduced to the given percentage of their starting value. The x-axis within each plot shows the results when the given fraction of a single age group shelters in place, in addition to physical distancing by the rest of the population. The result of this combination of sheltering and distancing is represented by a bar, where the color of the bar indicates the age group which engaged in sheltering, as is shown on the key in the right. The height of the bar yields the total fraction of population infected or the number of deaths in the population in that scenario. Each row gives the results for a single location, where the first two plots show the fraction of the population which is newly infected in the new wave, and the next two plots show the number of new deaths which occur. We found that sheltering in place by a single age group had the potential to produce a protective effect against transmission for the entire population. But which age group had the greatest impact varied across all three locations, thus highlighting the importance of capturing heterogeneity both within and across populations. Furthermore, the impact of sheltering in place is itself impacted by the level of physical distancing undertaken by the rest of the non-sheltered population. Here, 50% contact and 75% contact rates, which represent 50% and 25% reductions in number of contacts, are shown, with starkly different outcomes with respect to infections shown left and deaths shown right in our three populations of interest. This work suggests that partial population sheltering, rather than universal lockdowns, combined with physical distancing by the remainder of the population, may be a creative solution for reducing COVID-19 transmission in the months ahead, again, while we wait for vaccines to roll out, but that recommendations regarding who should be sheltering in place must be population specific. Given the impact of physical distancing as a supplement to partial population sheltering, we also provided a fairly long list of policy recommendations to improve the feasibility of physical distancing in our paper. These include, but are not limited to, the implementation of shift work, staggering of work shifts, and cohorting of workers in workplaces, one-way aisles and age group-based shopping hours for essential businesses such as grocery stores, pharmacies, and so on, staggered admissions for non-essential businesses such as gyms and restaurants, and remote worship services for religious congregations. Further recommendations, including the feasibility of sheltering in place within the work from home paradigm, are elaborated upon in the supplementary materials of this study as well for anybody who may be interested. This all said, though our ABM structure has been peer-reviewed and published, we're still working on improving it through related and ongoing work that builds off of the structure I presented today and applies it to other locations of interest. Internationally, we've thus far expanded our model to India, and domestically, we started working on developing state-level models that incorporate occupation into the agent characteristics as defined for each population of interest. At the state level in the US, we're also working on modeling forthcoming pharmaceutical interventions, such as the rollout of vaccines, and the vaccination deployment strategies that may best exploit transmission heterogeneity. The fact that not all individuals are as likely to contract or spread SARS-CoV-2 as others, to inform risk-based immunization. Without question, this is a very active area of research where we expect to continue improving upon our published work to better inform the way that we make policy decisions moving forward. And we're really excited to see where our ongoing work takes us. With the first of three studies I'll be covering today behind us, I want to maybe briefly take a moment to now start diving into another research area of interest at the intersection of machine learning and the COVID-19 pandemic, natural language processing for bibliometric analysis. As I mentioned at the beginning of this presentation, my group became particularly interested in understanding the evolution of research pertaining to COVID-19 due to how rapidly studies, including our own, have been produced in response to the myriad knowledge gaps that exist due to the novelty of the pandemic. More specifically, we were interested in answering three specific questions, which I'll go over quickly now. First, given that COVID-19 has caused a multi-million casualty pandemic and related coronaviruses like Middle East respiratory syndrome coronavirus and severe acute respiratory syndrome coronavirus, known as MERS-CoV and SARS-CoV, thus far haven't, does the research that's been produced to date for COVID-19, especially given the speed at which it's been produced, differ in some way from research that's been produced for MERS and SARS? Second, what fields or topics are thus far overrepresented and underrepresented in the COVID-19 literature that has been published, either as peer-reviewed papers or as preprints, which are research reports that are distributed through servers on the internet to allow for early dissemination of scientific findings prior to the peer review process. And finally, how is the focus of COVID-19 research, namely the topics and fields investigated, changing over the course of the pandemic? There are a lot of cool results I want to share here today and to really start addressing these three questions. So I'll only offer a very cursory look at the methods we used in this particular study before jumping into our findings. The paper is cited at the bottom of the slide, though, for those who would like to dig into the more technical aspects. To start addressing our questions of interest, we turn to the COVID-19 Open Research Dataset, which some of you may be familiar with. It's abbreviated as COVID-19, a growing resource of scientific papers on COVID-19 and related historical coronavirus research. As of May 28, 2020, COVID-19 was comprised of over 130,000 research papers. Remember earlier when I said thousands and thousands of research papers? I really meant thousands and thousands of research papers. To save computing time, we decided to restrict our analysis to abstracts, and of the research papers in the dataset, about 100,000 had abstracts available for analysis. Among these, about 35,000 mentioned coronaviruses explicitly in the abstract, indicating that the paper itself was about coronaviruses rather than simply referencing coronaviruses in passing or on the citation list. Over half of these coronavirus abstracts were about COVID-19. The remaining fraction referenced other coronavirus diseases, like MERS and SARS, instead. After the filtering process shown on the previous slide, we used the resulting 18,412 COVID-19 abstracts and the 16,869 abstracts mentioning SARS and MERS as the source texts or corpus of documents for our analysis. Natural language processing was implemented on these 35,000 abstracts in two different ways. First, we conducted dimensionality reduction using principal component analysis, which I've abbreviated here as PCA. PCA identifies patterns of variance or principal components, abbreviated as PCs, that differentiate documents from one another, highlighting key trends in the data. For example, in a simple corpus with two mutually exclusive topics, such as machine learning and public health, terms machine and learning would be correlated with one another. PCA would recognize these terms as an important source of variation, providing a way to differentiate documents about either topic, machine learning versus public health, by the frequency of these terms. Following PCA, we conducted topic modeling using latent Dirichlet allocation, abbreviated here as LDA. LDA is an unsupervised probabilistic algorithm that extracts hidden topics from large volumes of text. Once trained to discover words that separate documents into a given number of topics, LDA can estimate the mixture of topics associated with each document, or in our case, scientific abstract. These mixtures suggest the dominant topic for a document that is then used to assign the document to an overarching topic category. An example I frequently like to give is LDA may separate documents into two topics, one on machine learning and another on public health. And if a particular document's mixture is 60% machine learning and 40% public health, it would assign that document to a machine learning topic category. Findings from our dimensionality reduction via PCA suggest that the second principal component does a nicer job of differentiating literature about COVID-19 from literature about MERS and SARS, shown on the right. It's worth noting that earlier PCs usually capture more variance than latter PCs, but in this case, we see that PC2 captures more variance because certain aspects of pre-computation processing weren't conducted for the purposes of computational feasibility, which is detailed at length in the supplemental information that accompanies this particular study. To better understand what kinds of terms were driving the divergence we saw in PC2 between COVID-19 abstracts and abstracts pertaining to MERS and SARS, we examined the component values of the top 50 words on PC2. Here, we see that on the left, lemmatized terms include words like patient, case, and the term hospit, which represents words such as hospital or hospitalization, among others. Meanwhile, on the right, lemmatized terms include words like virus, cell, and protein. Notably in PCA, words with component values of the greatest magnitude on each PC most strongly drive the pattern that each individual PC recognizes. Here, this means that PC2 detects a pattern such that when protein appears in the text, patient appears less often. To learn more from the lemmatized key terms in the previous slide, we sorted them by their PC2 component values and then examined the percentage of COVID-19 abstracts and the percentage of MERS and SARS abstracts that mentioned each word. Here, COVID-19 abstracts are shown in orange and non-COVID-19 or MERS and SARS abstracts are shown in blue. It's immediately obvious that COVID-19 abstracts are overrepresented on the left-hand side, the side that includes words like patient and case, and underrepresented on the right-hand side, the side that includes words like protein and cell. Given the terms that protein and cell are more likely to appear in lab-based research, and terms like patient and case are more likely to appear in clinical modeling or field-based research, this suggests that lab-based research regarding COVID-19 may be underrepresented to date when compared to MERS and SARS. Digging deeper, topic modeling via LDA also suggests stark differences in the topics covered by COVID-19 or SARS-CoV-2 related abstracts to date when compared against abstracts pertaining to other coronaviruses. 30 topics emerged as shown above, and 5 of these, 1, topic 14, outbreaks impact on healthcare services, 2, topic 15, testing for coronaviruses, 3, topic 17, epidemic cases and modeling, 4, topic 21, clinical care and therapeutics, and 5, topic 25, lessons learned for epidemic preparedness, accounted for 58% of all COVID-19 abstracts and just 17% of MERS and SARS abstracts. In other words, COVID-19 abstracts were disproportionately concentrated in these 5 topics relative to non-COVID-19 abstracts. We were also able to group the 30 topics that emerged into a few topic families, namely 1, clinical issues, testing and diagnostics, 2, societies and outbreaks, responses to mitigate them and their impact on our society, 3, basic microbiological study, 4, general outbreak reporting, and 5, modeling disease transmission. Temporal analysis of these topic families over time indicates that publications between January 2020 and through the end of May 2020 were dominated by studies involving outbreak response in patients and healthcare services, with no sign of slowdown. Publications regarding viral mechanisms and biomolecular processes related to SARS-CoV-2 grew at a slower pace during this time period, and these results remain consistent when we reran our bibliometric analysis pipeline with data through July 2020. This suggests that as of this past summer, COVID-19 research has been dominated by clinical modeling and field-based investigation, whereas lab-based studies have lagged behind. With the help of colleagues and collaborators who conduct lab-based science, we're able to determine the most likely cause for the lag in lab-based research for COVID-19 is due to massive federal funding cuts that basic science labs have experienced over the last several years. In other words, these lags are not at all the fault of basic scientists. Instead, they represent insufficient resources to do work that is essential to pandemic response, including development of improved diagnostics and condition-specific therapeutics. As a result, one of our primary policy recommendations coming out of this study is the need for federal funding mechanisms to prioritize lab-based research, both in the short term for emergent crises like the ongoing pandemic and through long-term mechanisms that enable a position of preparedness for future emergent crises. Since publication of this study, numerous lab scientists have reached out to my group and thanked us for providing quantitative evidence for their anecdotal experiences, which they hope will help motivate reevaluation and redistribution of federal funding to lab-based research activities. Indeed, we foresee that our bibliometric analysis pipeline can be utilized by federal funding agencies over time to identify possible special interest areas too, including persistently understudied topics, not only in basic science, but within clinical modeling and field-based science as well. As a result, we are keeping our pipeline up to date and will continue running it on the COVID-19 dataset for the foreseeable future to see what else we can learn about the information we're creating in response to the pandemic. We also plan to expand our bibliometric analysis pipeline to include clinical trial abstracts to unearth potentially understudied outcomes associated with COVID-19, such as the long-term effects of COVID-19, which to date remain very poorly understood and have often been overshadowed by effects associated with therapeutics that are currently undergoing trials. Beyond bibliometric analyses, we would also like to further examine COVID-19 and other scientific literature databases using network science techniques to investigate the COVIDization of public health research. COVIDization of research may be defined as a phenomenon in which researchers who have not previously studied pandemics, epidemics, or coronaviruses are pivoting towards COVID-19 research for a whole host of reasons, varying from the availability of emergency funding to things that are a little bit more malicious, like opportunism. However, given the importance of domain expertise and experience when conducting research about COVID-19, the COVIDization of public health research has the potential to result in information generation that, maliciously or otherwise, doubles as misinformation propagation, as is showcased by several high-profile retractions from pretty prominent journals that have taken place since the beginning of the pandemic. Of course, poorly executed scientific studies aren't the only source of misinformation that plagues the pandemic, which leads us to the third and final study that I'll be covering today. In the broad research area of utilizing novel digital data sources for event-specific surveillance, this particular paper focuses on the public health impacts associated with a misinformation event that I'm sure many of us are all too familiar with. President Trump's April 23rd remarks regarding the off-label use of disinfectants as a COVID-19 therapeutic. For those who may need a refresher, let me read President Trump's remarks to you now, verbatim. I see the disinfectant, where it knocks it out in a minute, 1 minute. And is there a way we can do something like that by injection inside or almost a cleaning? Because you see, it gets in the lungs and it does a tremendous number on the lungs. So it would be interesting to check that, so that you're going to have to use medical doctors with, but it sounds interesting to me. Following April 23rd, my research group was interested in answering 3 specific questions. First, how did President Trump's remarks impact the behavior of the general public with respect to interest in purchasing, injecting, or drinking disinfectants? Second, how long did the impact of his remarks last? And finally, was this misinformation event associated with population-level increases in adverse health effects, such as poisonings? Like the bibliometrics study, there are a wealth of fascinating findings that we discovered through this investigation, so I'll keep my discussion of the methods brief and focus primarily on the results. However, please feel free to read the paper cited at the bottom of the slide and the technical appendix if you'd like to learn more. To start addressing these questions, we first turned to internet search query data from Google to get a handle on what kinds of disinfectants the general public was searching for both before and after April 23rd. Google search query data are fractional and relative. When interest in a term reaches a peak for a given time period, this means that the term was most popular at that point in time. And whichever term in a series of terms was most popular among them peaks at 100. Here we can see that Lysol was the most popular among the 9 disinfectants considered, and that it peaked around April 23rd. Other popular disinfectants included bleach and Clorox, with the remainder peeling away from the pack and lingering towards the bottom of this graph. With our initial search query analysis under our belts, we curated a set of search terms to represent 4 topics of interest: purchasing, drinking, and injecting disinfectants, as well as poison control, a proxy indicator for possible poisonings following the off-label consumption of disinfectants. As is clear from the search terms considered, we chose to focus on the 3 most popular disinfectants that appeared to peak around April 23rd: Lysol, bleach, and Clorox. We pulled data from Google search trends for these search terms, but we also pulled news media data pertaining to these topics as well, so that we could implement a debiasing procedure to separate interest in President Trump's remarks due to media-generated interest from true interest in the off-label use of disinfectants. The autoregressive machine learning procedure designed to debias the search query data of media-generated interest is detailed at length in the supplementary materials that accompany this paper, for those who might be interested in digging into it. Prior to debiasing the search query data of media-generated interest, we plotted our raw search query data, and the results, which are shown here, are pretty stunning. The action-oriented searches that reflected off-label use of disinfectants, namely drinking and injecting disinfectants, peaked immediately following Trump's April 23rd remarks. Then, rather damningly, interest in poison control peaked the very next day, results that are consistent with poisoning reports subsequently noted by the American Association of Poison Control Centers. Moreover, interest in these topics remained increased for an entire week following the misinformation event, suggesting that while most of the associated impact on population-level behaviors occurred soon after the event itself, the impact did not dissipate immediately. Though debiasing to minimize the news media-generated interest in these topics marginally blunted results across the topics of interest, as is shown in these 4 charts, the overarching trends described in the previous slide remained consistent. Though we can't infer causation from this work, the fact that internet search interest in poison control centers peaked after queries regarding off-label use of disinfectants suggests that search query data could be used as an early warning surveillance system for poison control centers in the future, a need that might be increasingly dire as false cures for COVID-19 continue to be propagated by those in positions of power. Which brings us to the policy recommendations that my research group made following this study. First and foremost, science communication at multiple scales will be necessary to combat sources of misinformation, including the White House, at least until Inauguration Day. Second, a surveillance system for public health misinformation should be established using novel digital data sources that allow us to monitor population-level behaviors following misinformation events. By designing such a system specifically for healthcare and safety service providers, decision-making tools like the early warning system for poison control centers I just mentioned can be effectively brought to fruition. With an eye towards establishing a surveillance system for public health misinformation, my research group is currently pursuing a geographic analysis to accompany the temporal analysis presented today to uncover spatial heterogeneities in population-level behavior and thus vulnerability following misinformation events, as well as sociodemographic risk factors that accompany such vulnerability to enable hotspot prediction of adverse health effects in response to misinformation events. We're also working on incorporating additional data streams like Reddit and Wikipedia to glean deeper insights into behavioral impacts following other misinformation events, such as falsely purported pharmaceutical therapeutics and black market purchasing of such products. And on that note, thank you all so much for listening. I know that I've covered a lot of material today, but I hope that the 3 studies I covered have effectively showcased a sampling of the advances that machine learning can achieve within the context of the ongoing pandemic and public health more broadly. Now, I'd be very happy to answer a few questions over Zoom. It looks like I have left enough time, thankfully, and please don't hesitate to reach out over Twitter or email as well. Thank you all so much.
There's a couple of questions in the chat. Are you able to read them? Do you want me to read them?
Why don't you go ahead and read them, Andrew?
So the first one asks, for the NLP bibliometric analysis, how do we assure saturation or global coverage, especially concerning non-English language publications?
That's a terrific question. So, I think any bibliometric analysis tool is going to run into limitations by whatever database we're using to conduct this analysis, right? So COVID-19 absolutely has its limitations. I think that the limitations are fairly well outlined. And I do think that one of them is absolutely, how are we accommodating research in other languages? And this is especially an issue, obviously, because Chinese researchers have conducted some really phenomenal work when it comes to our basic understanding of this pandemic, especially given where the pandemic originated, so on and so forth. And I think that that's been perhaps one of the biggest struggles to deal with. I think that we all acknowledge that there are some serious limitations in terms of tracking how Chinese language research is contributing to our understanding of this disease. And so very early on in the pandemic, one of the things that was happening that, for better or for worse, it's what happened is that a lot of Chinese labs were engaged in really important research, and they would essentially make sure to send all of their results in English language to large journals here that are largely based in the US, like the New England Journal and so on and so forth. And so that's allowed us to at least capture some of the research that's happening in places that aren't predominantly conducting research in English. But I think that one of the areas that we can and should absolutely expand into is really to start thinking about how do we expand into other languages. And there are some good examples of this, though. So when I was doing my PhD, my funding came through HealthMap, which is an organization that's based out of Harvard Medical School and Boston Children's Hospital. It's led by John Brownstein. And one of the things that they have started to do over the last, I guess now almost 10 years, is they've slowly started to add more and more languages in terms of data that they curate. And so they are a digital disease platform that does surveillance of infectious diseases. And they've successfully managed to expand to a lot of different languages. And I think that what we can learn from that is that it's certainly possible, but it takes time, and it generally takes curation expertise from real humans who are native speakers in the languages that we're interested in. So I think that in many ways, that is perhaps the future of bibliometric analysis, taking what we have learned from other sorts of surveillance tools for public health and trying to learn from them so we can expand our corpus to a broader, more global set of researchers.
Taufik, does that answer your question? You're here.
Yeah, it does. Thanks so much. And probably there will be opportunity, maybe in translator in future also, maybe would be another way to go. Maybe AI in translation and some other stuff would be.
I think that's a really interesting point. So, you know, I'm sure all of us are very aware of the advances that have been made in artificial intelligence and the role of AI and translation and how much improvement there's been in the last several years, especially. And this is actually a piece of the puzzle that I use myself when I'm doing curation of text-based data using algorithms. So one of the things that my group specializes in is data assembly. So this idea that a lot of times data exists in a lot of different formats that are not easy to access and are not machine readable. And so how do we curate these data and create something that's actually useful in terms of a data set? And so we have actually implemented the use of AI in translating non-English source texts to do this sort of data assembly for different sorts of public health problems. And you know, for the most part, it works really well, especially for languages that have a fairly large corpus to train translation algorithms off of, but we also see some serious deficiencies in other languages. So it's been really interesting. We've done this for Arabic, French, Spanish, and a couple of other different languages with varying levels of success. So I definitely agree. It's a really interesting area to kind of keep an eye on.
Do you want to ask your, let's see. Do you want to ask your second question in person since you're here? You had asked about the way agents are defined in the ABM.
Yeah, I saw the agents, you define two agents, one male, one female, and then you define the ages as well as the household, you put some numbers there. And at the end of the day, it seems as if those agents have some behavior that are population behaviors. So are we dealing with two agents, or are we dealing with two agents that are mimicking the behavior of the population?
That's a great question. Yeah, so this probably wasn't clear from the slide. So these two agents are just two examples of all the millions of agents that are comprised in the agent-based models that I presented. So for any given population, you probably have, in the case of the ones that we consider, right, Hubei, Lombardy, and New York City, these are large populations, right? So you want to simulate a large enough number of agents to reflect the populations that you're interested in. So the way that we define each of these millions of different agents is by looking at things like census microdata to understand things like their ages and what kinds of household contacts they may have, so on and so forth. And we also use contact matrix data to understand what the differences in contact structure might be for the different locations. So these two agents on that slide are two examples of folks that might be included in a larger agent-based model that has millions and millions of agents that are being simulated through this epidemic model. And I think, you know, there are lots of ways that we can improve upon agent-based modeling. So I'll also mention that here where, you know, personally, I think it's really interesting how much of an advance we've made in ABMs in the last 5 or 10 years alone. I often think about, you know, 10 years ago when I first started looking at ABMs as a possible method for studying epidemic dynamics, there was very little information on, say, how does contact structure differ in a place like Italy versus a place like China? And I think that now we're seeing these massive information generation projects and investigations that are giving us a much clearer picture of how populations are different from each other. And that allows us to do a better job of making sure that the agents that we calibrate look more like the agents that we might expect from the populations that we're interested
in. We have another question from the chat here. Starts with thanks for the great presentation. It seems like you're able to use mostly off-the-shelf ML techniques. Were there situations where existing ML techniques were insufficient?
Yes, definitely. So in the last study that I presented, the autoregressive technique that we developed to debias the Google search trend data based off of what we were seeing in terms of news media coverage on topics of interest. That's actually a brand new method. So this methods paper, I didn't go into it today. It's cited in that particular paper because obviously we needed to develop the method first, but that methods paper is up on ArcCiv and it's currently under review right now. But essentially, one of the things that we have known as a very serious problem when it comes to using search query data to do surveillance on topic areas of interest is that news media absolutely affects the way that people search for things. And this has been a long-term problem in terms of trying to understand how do we optimize the use of search query data for different sorts of public health surveillance. I'm sure most of the people on the line are very familiar with Google flu trends and the whole calamity that ensued with Google flu trends. I won't say that the bias of news media played a role in that assuredly, but I would say that that's probably a pretty strong hypothesis that the fact that during the swine flu pandemic, there was a lot of news media generation about the pandemic, that might have certainly affected the way that people were searching for the pandemic, and that absolutely affects then any sort of modeling approach that we use to convert the signal that we see from search query data into something that might tell us about how many cases there are on the ground. So prior to this pandemic, that was actually one of the primary areas of my study. How do we use Google search query data to understand how many cases are happening of a given disease in a given location when public health surveillance is not sufficient? So when we can't do diagnostics, when we can't do large scale diagnostics especially. And so my work with Zika in Central and South America was a really good example of this, where we implemented Google search query data to kind of try to figure out how many cases of Zika were happening in Colombia. And the reason that we did that there is because Zika is one of these diseases where antibody tests have serious cross-reactivity problems in locations where you have a lot of vector-borne disease, like in Central and South America. So you need PCR testing, otherwise you can't figure out whether somebody had Zika or not. And during the Zika pandemic, there were such shortages in trying to get people PCR tests that they were delayed, months and months at a time. And so in a situation like this pandemic, where the cases were generally pretty mild, but there was the possibility of passing on birth defects in pregnant women who got sick, you really want to be prepared for potential surges, especially in terms of pregnant to be moms who might be seeking care in facilities who think that they might have Zika. So you want to be able to kind of tell how many cases there are. So that was the entire purpose of trying to configure a Google search trends based surveillance system for that particular pandemic. But one of the things that I learned personally during that time is that there were serious problems with news media data driving search interest in this particular topic. So while we were working on this paper, we kind of figured that this is a serious limitation. We need to figure out some way to de-bias search query data of the fact that a lot of times people search for things not because they think that they have something, but because they saw it on the news. And so this is one of the really interesting recent areas of methodological study that my group has done. And as I mentioned, we implemented this de-biasing method kind of for the first time since the publication of the method as a preprint in this Lancet Digital Health paper that I presented today. But I think that that's a really interesting example of how you can identify a need and realize that, okay, we need to develop a new method for this. And so, are there ways to improve? I think absolutely. I think that our de-biasing method does a pretty decent job. It's certainly much better than using the raw data, but I think that there are lots of areas that we can improve, and I think that this is perpetually the nature of developing new methods. But I think that was of recent research, this is probably one of the areas that I'm most excited about in terms of developing a new machine learning method to address a problem that we have known has existed for a really long time. And to give some context as to why we can do this now and we couldn't before, the data source that we used for news media to identify the amount of volume of news media on a given topic, this data source, Media Cloud, is a fairly new data source. It hasn't been around forever, and as a result, we weren't really able to have like a really steady stream of the volume of news for a given topic to start to think about this question in a really rigorous way until pretty recently. So this is an example of how sometimes new data sources can enable methodological development as well.
We have time for one more question.
Just wanted to say thank you. That was a very, very detailed answer to my question and really, really appreciate it.
Of course, thanks. That was a great question.
Can you tell, I mean, can you delve a little bit more into the ABM? What packages are you using? Are you doing it from the scratch, or are you using some packages? Are there limitations with the packages? Or what are the issues around the ABM that you would like to share with us? Because to me, I see ABM very powerful, because there are some packages that combines ABM, dynamic simulation, and discrete simulation, the likes of AnyLogix, and there's some site makers and some other stuff. So which ones do you use? Are there limitations, or do we have some kind of, because I see it very powerful.
Yeah, definitely. I agree that there are some serious limitations with off-the-shelf approaches to ABMs. I think this is actually especially true for epidemic modeling. So we know that ABMs can be used for lots of different applications, right? So one of the issues that I personally have seen in terms of how we use, especially off-the-shelf packages, is this idea of, how do we use domain level expertise to inform the way that we are calibrating these models, right? So in terms of, what our code is, what it looks like, so on and so forth, this is actually all available on GitHub. So if you go to the paper that I linked in the slideshow and click through to the GitHub, you will be able to read all of our code and see exactly what we did. But I think to answer your broader question in terms of, what are the limitations with our study? What are the limitations with ABMs in general? I think one of the biggest limitations to me personally is when there are too many free parameters. So I think this is something that, I'm sure many of us share this opinion, but this is something that I've had plenty of very, very long discussions about. But this idea that we want to inform the choices that we're making in our model with information that we have. And I think that especially when we're applying ABMs to real world problems like epidemics, this is when you really need domain level expertise to be able to tell you, well, we do have some empirical evidence for this, so let's try to use empirical evidence instead of treating this as a free parameter, is one kind of way to start dealing with this conceptually and philosophically. But I think also, there's something interesting about, how do we constrain, so when we have free parameters, how do we constrain our priors, right? So this idea that even when we have free parameters, we should have some domain level understanding of what are realistic possible outcomes for those free parameters. And I think that this is a shifting paradigm in ABMs where even 5 or 10 years ago, and in some ways, perhaps because of 5 or 10 years ago, a lot of the work was less applied and more conceptual in a lot of ways. I think we're starting to move towards a philosophy where we want to start reducing free parameters, where we want to start constraining our free parameters using domain level expertise, in addition to really making sure that the parameters that we can calibrate empirically, we're doing so. So I think that this is, more philosophically, what I think are some of the limitations with the modeling space in ABMs in general. But in terms of specific limitations to our study, because I'm now running out of time, there is a very, very lengthy list of limitations in our study. I definitely encourage you to read it. We spent a lot of time thinking and talking about it. And, Andrew was on that paper, Moon was on that paper. A number of folks on the line are quite familiar with it. Brian is also on the line and was our first author. But I think that, we are very cognizant of some of these limitations that I've discussed today. And I think that we tried our best to outline them as well as we could in the study itself.
Thank our speaker again. And thanks to everyone who came to the talk.
Thanks, everyone.